Good morning, everyone. Thank you for joining us this morning. Our presenter today is Dr. Darren Joseph. He is a fantastic physician, but also pulmonologist. So we appreciate his insights on hematophysis. Dr. Joseph works here at Mediclinic Midstream, but is still also working at Steve Biko Academic Hospital. And we're very grateful to have you here this morning.
Thank you. I don't think I've already made introductions. Everybody knows who I am. So it's ironic, we just had a talk from a rep about anticoagulation, but I'm talking about patients who are bleeding. So I think it's a common topic. It's stuff that we see. I think I might see more of it maybe in the state than you do because of all of our cavitatory TB and malignancies and things that we see so often. But I think it's common and quite practical, I think, for everybody. So hopefully it's more of a practical discussion than a theoretical one. So I think we all know what hematoptysis is. It's coughing up of blood, but it's blood that originates from the lower respiratory tract. So it has to be differentiated from pseudohematoptysis, which we'll talk about in coming slides, but that is blood that obviously originates elsewhere. And it's quite variable in a degree, so you could have just mild streaking of sputum, but obviously you can have massive hematoptysis with large amounts of pure blood that can cause hemodynamic and respiratory compromise. So we don't really talk about hematoptysis in terms of volume anymore. So that term massive hematoptysis is not really something we use. We rather talk about hematoptysis that's either life-threatening or non-life-threatening, because quite often what is life-threatening has nothing to do with the amount of blood. It's got more to do with where that blood is and the effect that it has on the patient. And that often has a lot more to do with the patient's underlying condition and the volume itself. So the term massive is not really favored. It can be idiopathic or cryptogenic is what the terminology is in this case, and often iatrogenic, but usually there's an acquired cause. And the interesting thing is hematoptysis is often the first sign of whatever that underlying disease is. So people often walk around with a lung malignancy for a while, and when they have hematoptysis, that's usually the thing that brings them to hospital where the disease is discovered. So it's often the presenting complaint. The main focus of management is actually directed at the underlying disease and not really at the hematoptysis itself. So we do have to manage it, but really the whole point of management is to get to the point that you can diagnose and manage the underlying disease properly. So we classify it as non-life-threatening or life-threatening. And traditionally, as we said, this was based on volume, but we know that that's very difficult actually to quantify. You never really know how much blood was coughed up before the person got to hospital or even in hospital. So it often leads to big over and underestimations. And what's more important is the patient's underlying reserve. So what does the rest of the lung look like? What is their underlying cardiac function? That really determines how they will cope with any given amount of hematoptysis. So the clinical relevance is actually more significant than volume. And I don't know if some people like mnemonics, so to keep it practical, the ABCD of, that's the definition of what is life-threatening. So if it causes an obstruction of the airway, any abnormality of gas exchange, any hemodynamic instability, it's life-threatening. And the last thing is the actual degree of blood loss. And even that, there's a total lack of consensus. So some people will go as low as 150 or even 100 mils. Other people can go up to 600. And some people will use an hourly rate. So if it's 100 mils an hour, then they will define that as massive. But really, it's the instability in terms of breathing and hemodynamics that's more important. So just to remind you of the anatomy of the lung actually has two blood supplies. So there's the pulmonary arterial circulation and the bronchial circulation. So the majority of the lung is supplied by the pulmonary arteries, but the bronchial system is actually more significant when it comes to these life-threatening bleeds because it's under systemic pressure. The bronchial arteries come off the aorta and its branches. And so when you erode into those vessels, the bleeding tends to be more massive. Even though it only supplies a smaller amount of the lung volume. There's different ways that you can bleed. There's obviously, you can erode into a vessel, infarction, which can lead to bleeding and inflammation from vasculitis, aneurysm rupture, and patients can also have an underlying bleeding disorder. So you need to just think about all these mechanisms when you're thinking about causes. So the most important cause to rule out is pseudoheamoptysis. So this is heamoptysis, or the coughing up of blood that is actually aspirated from a source outside the lung. So it's either from the upper respiratory tract or the gastrointestinal tract. And about 10% of all presumed cases, and I think it might even be more from my experience, is actually due to pseudoheamoptysis and not heamoptysis itself. And then an interesting one is this organism Serratia marcescens, which actually gives you this reddish discoloration of sputum and lavage fluid. It looks just like heamoptysis, but it's from this red pigment that it produces. And obviously, when you send this fluid off, there's no red blood cells there. You culture the organism instead. And there's actually a picture of a shower floor where this organism was growing. You can see how it stained the tiles and everything red. It looks like blood, but it's a form of pseudoheamoptysis. So there are certain things that can give you clues that this is not coming from the lung. So what favors, if it's coming from the nasopharynx or the upper respiratory tract, you might see blood in the nostrils. I mean, that's a pretty obvious sign. Patients may complain that they have a sort of bloody, they can taste blood at the back of their throat. It's like a bloody postnasal drip. They might give a history of bleeding gums or a bleeding lesion in their mouth or throat. They can have symptoms of acute pharyngitis. And ideally, you would do a proper ENT evaluation with a nasolaryngoscopy, then you can rule that out. GIT bleeds are a little bit more tricky, but the clues there would be that if the blood looks coffee ground or it's dark in appearance, low pH, if you see food within that material, then you know it's coming from the gut. And if the patient has a history of vomiting or Melina stools, and especially if they have a history of liver disease and other GI disease, that's a big clue that it's coming from outside the lung. The bleeding from the lung tends to be bright red. It's often frothy because it's obviously mixed with air from the lung. It's more alkaline. And then what we test for if we do a lavage is we ask for hemosiderin-laden macrophages. So the job of a macrophage in the lung is to engulf and phagocytose any foreign material, including blood. And so you can test macrophages to see whether they have any blood, the degradation of blood within them, to see whether there was any bleeding in the lung, even if you can't see blood itself when you do the bronch. So the remaining causes, you can categorize them into different groups. So tracheal, bronchial, or airway diseases are important because most of the massive bleeds or the life-threatening bleeds come from these, especially bronchiectasis, and we see a lot of non-cystic fibrosis bronchiectasis, acute and chronic bronchitis, bronchial carcinoma, obviously very important. Carcinoid, more common than you think. We had one recently at Steve Biko, and a tracheal tumor that was a carcinoid, we think. A foreign body in the airway, which causes erosion over time, and often the history of an aspiration of a foreign body, you don't get it. It can happen a long time in the past. The person's obviously forgotten about it already. There's this interesting thing called Dieulafoy disease, which I'll come back to just now, so hold that thought. And then there's some pulmonary vascular diseases that are important. So obviously an embolism, if it progresses to infarction, they can bleed. Rasmussen's and other forms of aneurysms. You can have both increased pulmonary and bronchial venous pressures from either cardiac failure, mitral stenosis, although we don't often see massive bleeds from bronchial occlusion much with mitral stenosis anymore for some reason, but it is described in the books. And then AV malformations, I've seen quite a few of those over the last few years. I think it's more common than we think. People often present with heamoptysis as their first symptom. So this was a patient that we had a couple of months ago who presented with bleeding, and she had low saturations but was very comfortable on room air. And these sort of saccular lesions that you can see there in the middle lobe, those are actually blood vessels. You can see how they take up contrast. So those are all AV malformations that then had to go for coiling. Oftentimes when it's extensive like this, you actually have to remove that lobe to correct it. So parenchymal disease here, infections in our setting is obviously the most important, especially TB and mycotomas. Necrotizing pneumonias are also important, and then classically they describe these different types of sputums that you get. So pneumococcal they describe as being rusty in nature, and that picture on the left there is supposedly what rusty sputum looks like. So it's kind of brownish dark with sort of streaks of red through it. Staph gives you these severe necrotizing pneumonia. So it's blood, and you often have purulent secretions with the blood. The classic is red currant jelly or like strawberry jam appearance with Klebsiella pneumonia. That picture in the middle kind of gives you an idea. If you have lung gangrene, which thankfully is not that common, you can see blood, and you can actually literally cough up necrotic lung tissue with that blood. And amoebiasis in the lung gives you this anchovy paste or anchovy sauce appearance. So it's this kind of purpley red appearance like fish paste. So other parenchymal things, lung abscess, vasculitis or capillaritis, and then connective tissue diseases, including Ehlers-Danlos. And then there are other miscellaneous things. So you can have a coagulopathy or bleeding diathesis, trauma. So even things like rib fractures can sometimes cause bleeding, lung contusion and inhalational injuries, inhalation of certain drugs like crack cocaine, e-cigarettes. So vaping is not as innocent as people think. There's a whole bunch of interesting bleeding syndromes related to menstruation. So you get these cyclical bleeds, catamenial heamoptysis, you can have catamenial pneumothorax, catamenial hemorrhagic effusions, all related to the presence of endometrial tissue where it shouldn't be. And heamoptysis is another one that can be catamenial. We actually had a patient not that long ago with this. Pulmonary amyloid, something that people don't think about, but can also present with bleeding. And then hereditary and hemorrhagic telangiectasia and other forms of telangiectasia can also be a cause. So this is a patient that we bronched a couple of years ago. So she had systemic sclerosis, the limited cutaneous form. And she had the CREST syndrome, which, the T of CREST is telangiectasia. And we were expecting her to have some form of TB or necrotizing process because of the immunosuppression that she was on. When we bronched her, we saw the main airways were all full of these telangiectasia that were bleeding. So it's not common, but it can happen. Iatrogenic causes, so even intubation and just suctioning patients that are intubated, if people can cause injuries there. We can obviously do it when we bronch them. And then finally, if you've excluded all of these things, you can call it cryptogenic. So cryptogenic is actually more common than we think. So it can be up to 30%. I think that's maybe a little bit high. Closer to 5 is probably what we see. But it's once you've ruled out an obvious cause with CT and bronchoscopy and basic investigations, you can call it cryptogenic. And a lot of them could be due to this disease that I alluded to earlier, Dieulafoy disease, which is basically a superficial bronchial vessel that is below the epithelium. So when you scope them or you do a CT scan, you can't see this vessel because it's not that big and it's hidden below the epithelium, so you don't see it. But they are there and they can bleed and can often give you these supposedly cryptogenic forms of heamoptysis. So that picture there is actually a patient, it's actually a medical student that we had at UP, who came in with what he said he had severe heamoptysis at home. He had normal x-rays, normal bloods, vitals were all fine. We took him for bronchoscopy. The bronchoscopy was completely normal. So we said either it's a form of pseudohemoptysis coming from somewhere else, or weren't really that. We thought maybe he's malingering a little bit. So we discharged him. He came back the second time. And this was the second time. It came full of blood on the linen saver there. Again, normal imaging. We took him back for another bronchoscopy. Again, it was completely normal. He went for gastroscopies. It was normal. ENT saw him normal. We just couldn't find the cause of bleeding. So we're still a bit suspicious, but now a little bit more believing. And then he came back a third time.
Oh, God.
No, by that stage, no one wanted anything to do with him. They didn't want to take him. He had two gastroscopies. The ENTs had seen him twice. Everybody had said it's not their problem. So to prove that, we really thought that he was malingering. So to prove it, we said, we'll do a third and final bronchoscopy. We're not going to do another one. We did another scope. It was completely clear that the effluent that we lavaged off was like clear water. And we said we're going to send for hemosiderin-laden macrophages to prove that this is not from the lung. It came back positive. So he definitely had hemoptysis, But we 3 scopes, 2 CT scans, 2 gastroscopies, ENT, still never found the cause. So we suspect it was this. And to this day, we still don't really know where the bleeding was coming from. You can also have areas of hypervascularization. And then there is an idiopathic form of diffuse alveolar hemorrhage, which we call idiopathic pulmonary hemosiderosis, but that's not really today's topic. So then I don't know if there's any junior doctors or fellows or anything listening, but this is a nice exam question for people that are still going for exams, that you can have quite severe heamoptysis with an apparently normal X-ray. And I like to ask what the differential is, and so there it is. And then for massive bleeds, obviously anything can be life-threatening, but the most common that we see is, again, ABCD, aspergilloma, bronchiectasis, carcinoma, and in our setting, TB. I think we know that those are the big 4. And then if you remember your clinical medicine textbooks, you'll find this mnemonic there, battle camp, which is a common way to remember all the causes. All right, so mortality is quite high, actually. So it can be up to 30% with severe heamoptysis. But what's important to remember is that the risk actually increases with time, because often the thing that's causing the heamoptysis has a mortality associated with it itself. So if you have a lung malignancy, for example, and your presentation is with a bleed, your mortality is from the index presentation, but also over time, your risk is going to increase. So it's over time a very significant mortality risk with heamoptysis. Cryptogenic, because the whole aim of management is to treat the cause. Because you don't know the cause when it's cryptogenic, the mortality is even higher. It's up to 50%. And what's important for management is that if you do surgery as an emergency, so emergent surgery, there's a very high complication rate, a very high morbidity, and also an associated mortality. Compared to if you do elective surgery later on, after you stabilize and optimize the patient, the mortality and morbidity drops a lot. So we don't really do surgery in the emergency setting anymore unless you really have no choice. It's because of all of those associations. Okay, so management. So again, we divide it up into life-threatening and non-life-threatening, and the priorities are different. So if it's life-threatening, the priority is resus. If it's non-life-threatening, find the cause. So there's a few myths around management. So we try and just be practical and dispel some myths and give some advice. So obviously we start with the airway, because the principle of this is that patients with massive heamoptysis die from asphyxiation and don't die from bleeding out. It's not the hemodynamic effect that causes a problem, it's that they drown in this blood that's in the lung. So the best thing that you can do to defend the airway is actually to allow the patient to do it themselves and allow them to cough. The cough reflex is really protective, and so you don't really want to suppress that. And we'll talk about intubation in a second, but intubation is a form of cough suppression. So actually, unless you have no choice, you allow them to cough. Let them get the blood out of their lungs because they are defending their airway. You don't put face masks on and obstruct the airways, especially non-invasive. You'd rather not give that. Give high flow or nasal oxygen and assist them with suctioning as much as possible. These for breathing and bleeding side. So you always support them with some form of oxygen and put the bad side down. So you try and isolate which is the likely side of bleeding and let them lie on either their left or their right side, depending on which side is worse, to allow gravity to cause the blood to pool just in that sick lung and not affect the healthy lung. So the question is, well, when should you then intubate for airway protection? Because the ideal is to have the patient protect the airway themselves. And you must remember that we always think we are protecting the airway by putting a tube in it, but here the bleeding is coming from the airway itself. So you're not protecting it from blood. The blood's going to be there whether there's a tube there or not. And intubation will disable their own clearance mechanism. So you have to remember that there are indications for intubation. And really, it's if the rate of bleeding is overwhelming their ability to clear the airway themselves. If they just can't keep up with the amount of blood, you have to help them, intubate them and ventilate and suction for them. If there's already a severe gas exchange abnormality, then you have to take over and ventilate them. And then lastly, and the least significant reason is if they're too unstable to be moved without intubating them. Because really what you're gearing up to is either a CT or some form of intervention, and you have to be able to get them there to do it. So you might have to intubate them for that purpose, but ideally you have an unintubated patient when you do all of these things. So if you are doing intubation, consider getting help because it's difficult. There's blood in the airway. Patients are often unstable, so you need someone who's quite slick with intubation, often an anaesthetist. And you can consider even doing it in theatre because the patient might be ending up there anyway. If you intubate, it's the 0.12 rule. So the naught is for a big tube, so a big O. So anything bigger than size 8, ideally. And that's to facilitate your interventions and suctioning, thrombus removal, etc. The 1 is to remind you to consider single or main stem bronchus intubation. So if you're bleeding from the left lung, it's easy because you can just push the tube down blindly. It will usually go into the right lung. Otherwise, you can guide it at bronchoscopy. And obviously, if you're doing single lung ventilation, you must remember to adjust your tidal volumes. You can't give them normal tidal volumes. Dual lumen tubes is something that's quite controversial because they're quite difficult to place. They can often shift and move around. It requires a lot of expertise. And the biggest problem is that you can't bronch through them. So once they're in, you can't really do much. And you have to change them anyway quite early because otherwise they give you pressure necrosis and tracheostenosis. So they're really, it's often this thing that people think about. It's like the go-to for heamoptysis, but it's actually really a poor option. So try and avoid them if you can. C is for circulation, obviously, and then causing a clot. So we manage patients as normal. If there is an obvious bleeding problem, you can correct it with blood products or medication. And then what we do quite often now is we give nebulized tranexamic acid. So there are studies that show that it actually has value. It's well tolerated. People don't cough or have worse side effects when they use it. But it's never been studied in massive heamoptysis. There's a few case reports that show that it seems to work, but it seems to be a relatively safe, inexpensive, and effective way to help with clotting. So you just give 500 mL and mix with saline and nebulize it. Then really what you want to do now at this stage is you want to know, more important than the actual cause, is where is the bleeding? Because once you know the site, you can then isolate it and manage it while you're still working the patient out. So the main investigation initially is the chest X-ray, but this follows sort of a typical process of history, clinical exam, investigations, and the order that you do it, because the patient is unstable, is often a bit jumbled up. But really, so history and exam, obviously you try and do it as much as possible. The aim is to try and exclude pseudohemoptysis, try and quantify the hemoptysis, and really just try and identify major risk factors, the big stuff. You want to see if you can kind of get closer to a diagnosis there. Blood investigations, these are the initial things that we kind of do routinely, and they're sort of pretty obvious. But every patient should get a chest X-ray. And the main reason is it's not often diagnostic. Only in a third will it tell you the diagnosis, but it at least can tell you or give you a clue as to where the bleeding is likely coming from. And this is important because by the time you get the patient to CT scan, often the blood has moved around. They've aspirated it into a healthy lung or into a different lobe. And then you see these patches on scan, you don't actually know where the bleeding started. So the chest X-ray can help with that. And also it allows for imaging while the patient is still relatively unstable. You can do it in a resus setting and do a portable X-ray without having to move the patient. So X-ray is still important here. But what you're gearing towards is getting a CT scan, because the CT scan is the thing that is going to help you with diagnosis. It's going to localize the bleed. And often you don't need to do anything else after the scan. So, you don't, everyone wants a bronchoscopy in patients that have hemoptysis, but actually the most important investigation is a CT scan. Bronchoscopy is actually inferior to a scan in terms of diagnosis and in terms of location. So the target is to get it within 24 hours, but actually within 6. But it does require a stable patient in order to do that. E is basically for everything else. So you're going to give antibiotics. You can give bronchodilators if the person's bronchospastic on top of the bleeding, so that there's no issue with bronchodilating these patients. Circulatory support and donation, and then obviously you're going to monitor them ideally in a high care or an ICU setting. And then only later comes this idea of bronchoscopy. So it is a useful adjunct. Again, its main function is to determine the location of bleeding, because often you can't see the lesion that's bleeding, you just see where it's coming from. And really only if either the X-ray or the CT is non-diagnostic. Otherwise, if you know where it's coming from, you know where it is, you don't need a bronchoscopy because you can't do much once you're there. The reality is flexible bronchoscopy is limited in terms of what you can do for the patient. So the yield is about 50% compared to 75% for CT. So CT is superior. And it can be used therapeutically, but it's not its real function. So we won't intubate someone just for the purpose of being able to do a bronchoscopy, because you have all the complications then of intubation. You only intubate if you have no other choice, and you only do a bronchoscopy if everything else has come back negative. It can be performed right at the bedside in a patient that is a little bit more unstable, which is advantageous. And then what is also quite useful is, so obviously if you bleed, you also clot. So if you have a significant heamoptysis, you can also have clot in the airway. And bronchoscopy helps you to be able to break up and remove those clots that might also be causing blockage. And then, like we had with our patient, if the source, you still don't know where the bleeding is coming from, you do limited lavages of each segment of the lung, and you send that for hemosiderin-laden macrophages, and you label those samples, and then later on you can identify which segment was likely the one to have been bleeding. So it is useful for locating the source of bleeding if you can't get it any other way. So what we can do if we do a scope is we can try and stop bleeding. So the easiest thing is compression. So you see where the blood is coming from, you just jab the scope into that segment and leave it there. And the scope itself will cause a tamponating effect. If that doesn't work, you can also insert balloon blockers, so like a Fogarty catheter, which you can insert down the working channel of the scope, and you direct it into the segment and inflate the balloon. You can leave those in if you need to. Cold saline is also useful, so you just put like ice water down, leave it in to cause vasoconstriction and hopefully coagulation. You can use various agents down the scope as well. So we often use adrenaline, so diluted adrenaline, you inject it down the scope, but that does have hemodynamic effects. It gets absorbed. Cyclocapron is actually quite useful. So I always, if I do a transbronchial or an endobronchial biopsy, I always put cyclocapron in, even if they're not actively bleeding, because it's well tolerated, it's safe, and it seems to help. And then if you're lucky to have things like argon laser and other forms of laser, you can do cauterization under vision. But really the role of treatment with flexible bronchoscopy is quite limited. Rigid bronchoscopy is much better, but that requires sort of someone with expertise and cardiothoracic surgical expertise. Okay, so what next? So you've controlled the bleeding. Now your whole focus shifts to finding the cause and treating the cause. But there'll be a group of people who either don't control or they have recurrent bleeding. And so here we said that surgery is inferior because of the morbidity and mortality associated with it. So the next step is interventional radiology or angiography and embolization. So this can help. You can actually locate the bleeding site with arteriography. You see this blush of contrast, you know it's bleeding from that point. And then while you're there, you can also treat it with embolization. So they will usually inspect the bronchial anatomy first, because that's responsible for most of the major bleeds. But as we know from cardiology, there's the anterior spinal artery is quite close to where they're working. And if you include that, you can have anterior spinal syndromes and paraplegia, which is a risk in about 1%. So not that high, but it exists. So people need to be told about it. It is quite successful, so about 85% it will control bleeding, but there's a significant rebleeding risk, so they do need to be monitored. And that's because either there's incomplete embolization or revascularization for some form. So you can do it in different ways. So coiling, that's an example of what a coil would kind of look like. I know Prof uses these plugs, vascular plugs here. He prefers them. He says they're a little bit more effective, but it is a bit more expensive. But there's other materials, other chemicals and things that you can also use. So this was a patient who, again, had an arteriovenous malformation. So I don't know, you can see here, there's all of that whole opacity there. So she was misdiagnosed as a pneumonia. And actually all of that was just big sort of a big sack of blood vessels that was sitting in the upper lobe. She went for a coiling procedure. You can see all the coils sitting now and closing off all of those vessels, and now the lucency of the lung is back because those vessels are now obviously not being perfused anymore. So surgery, it's really limited because typically you have to remove the whole lobe. So on an elective basis, if you're doing a lobectomy, you have to work up the patient to see, are they going to cope with the lobectomy? So you have to do certain calculations based on lung function and exercise testing to see, can they cope with the loss of that lobe or the loss of that lung. But here you don't get an opportunity to do that because the patient's too sick to undergo these tests. So you never really know how they're going to cope with the surgery until you do it. And so a relative contraindication would be patients who've already got diffuse lung disease. Active TB is a bit controversial. The surgeons like to hide behind that, at least it's the B code, because they're obviously worried about contracting TB. Obviously, if you're working directly on a lung that's infected, you are at risk. But they have gone so far as to ask us to put the patient onto TB treatment empirically for anyone with heamoptysis before they will do a lobectomy, which we're constantly having issues with them about. So they like to use it as an excuse not to operate, but it's a relative contraindication. But basically, you only do it in patients where nothing else has worked, where you have no other choice, or with very specific indications. So iatrogenic and traumatic lesions often require surgery, and certain aneurysm ruptures and bleeding AVMs, they sometimes require surgery up front. But the rest can often be controlled, and you plan for surgery later on once the patient's more stable. So non-life-threatening heamoptysis, really the whole point of this is to find the cause. So they generally have a good prognosis. They usually respond well just to conservative management. In fact, the patients often don't even require inpatient workup. They can even be worked up as an outpatient as long as it's not delayed. And you really want to find the cause and treat that. So again, you go through the same process like any other patient, taking a history and doing basic investigation. The history is really geared at red flags. So those are some of the things that you will ask about. So if they have any of those things, you'll obviously keep them and work them up a bit more strictly and a bit more quickly. If those are absent, there's room to be a bit more conservative. So basic investigations, and then you might add on some investigations depending on what you find. So you can get more specialized. Here, the most important study again is the X-ray. So if you have a normal X-ray, you must remember it doesn't fully exclude anything that could be sinister, but it goes a long way into reassuring you that there might not be a significant process here. So if it's normal, remember it excludes pseudohematoses. But if you've done that and there's no red flag symptoms, and you think that the patient's history is compatible with an acute bronchitis, then you can actually stop, treat the patient, and watch to see if there's any recurrence and follow them up to see whether anything develops. If there's an abnormality or there's any red flags, then you should investigate them further, and then the modality is a CT scan. So normal imaging, if it's normal CT imaging, you should follow that up with a bronchoscopy. We usually do that, but that is also a little bit controversial because those studies that I've put there, they actually have been shown that if you just do watchful waiting, it's as safe as whether you go all out and do bronchoscopy at that point. So it is safe to wait. So if you do a bronchoscopy, if you're thinking of doing one, you should do it when the patient's actually bleeding, because your yield is going to be much higher than if you wait and do it later on. And then obviously, if you find something abnormal in any of these tests, you might have to do further testing, and that'll kind of depend whether you have an isolated lesion or more diffuse lesions, depending on what you do next. So that's really the talk, but some take-home messages is just to say that it's a common problem, can present with a whole variety of severities, from very mild to quite severe. And it's better to assess that observing the clinical effect rather than the volume of blood. The priority with life-threatening disease is to stabilize the bleeding before you work up the cause. And it was non-life-threatening, you're really worried about the cause itself. Remember that asphyxiation is actually the biggest problem, not the bleeding. So you need to protect the airways, and the best way is to let them protect the airways themselves, let them cough. and only intubate when you really have to. So priority should be given there, and subsequently with CT imaging. So CT is really what you want to make a diagnosis, both in terms of locating the bleed and determining what the likely cause of that bleed is, and being used then to plan what subsequent management you want to give the patient. So it's more useful than bronchoscopy, but bronchoscopy does have some advantages because you can use it to intervene, and it can be done in a patient that's a little bit more unstable than what you need for a CT scan. Refractory patients, the best thing is to get interventional radiology if you're fortunate to have an interventional unit where you're working. And surgery is really a last resort because of its high morbidity and mortality. So there are only certain cases that will benefit from upfront surgical intervention. And that is that.
Thank you so much, Darren.
Thank you.
It's really helpful. I think I'm going to allow for some questions from the online people first, I think.
That's good.
Is there any questions from anybody that's watching online, listening online? Okay.
Thank you, Darren. I think it's really a very nice presentation. I mean, it's kind of Heamoptysis is something that we deal with on a daily basis, and most patients are really very terrified when they see the blood. Even sometimes sputum, just like slightly kind of discoloration of sputum, they really goes into panic. That's why probably if you look at the current definition, they look at life-threatening and non-life-threatening. But obviously it depends. I think that should be really for the doctor, not for the patient, because the patient with a small even blood, they will always think that it's life-threatening. So I think it's really up to clinician really to kind of tease out the history and perhaps actually make an accurate diagnosis. But yes, I think it's a common problem. I think you highlighted very well. And one of the common causes of Heamoptysis is that for non-life-threatening is bronchitis, even post-viral infections. Patients really do call blood or blood-stained sputum. And most of these patients sometimes just need reassurance. So I think, yeah, we see it quite common in pulmonology clinic and also, I mean, actually on the outpatient emergency department, actually. So we see quite a lot. So for me, it's quite a very good. I've learned something new. And I think it's probably, tomorrow will be better for me. Yeah.
Is there any reason in a non-life-threatening hemolysis to suppress cough?
I think only for patient comfort. So,
Okay.
In nothing that I read in any source did they mention DF118 and all these things that we used to use.
We used to do that, yeah.
It's really just for patient comfort that you give them something to soothe the cough and maybe dampen it down a little bit.
I think we have done that before in the context of the post-TB bronchiectasis, where patient we know the source of the cough, like source of the bleeding, like for example, post-TB bronchiectasis. So now when they have Heamoptysis, what we do normally, we do give them codeine and morphine just to decrease the amount of cough. While because the teaching was that if somebody have already existing bronchiectasis with mastectoma, when they bleed, normally because they're having secondary acute infection, and most of the time even probably secondary TB. So those patients would benefit from the control of the bleeding, use medication first. And if it doesn't work, then we consider them really for this one, for the embolectomy, or sometimes that you have to do really resection of that lobe of the lung that is damaged. I think that's probably in those cases. But in patient with Heamoptysis that we don't know and we don't have underlying cause, I think probably is not advised. If advised, then have to be proper short-term treatment where you're looking for underlying cause. But in terms of the life-threatening, yes, you can give them. But I think again, you just, it's not, you need to really treat the underlying problem.
So even for non-Heamoptysis cough, patients who have like hypersensitivity, post-infectious, even
there's really no,
it's fallen out of favor.
In any scenario.
So LAMAs work quite well. So muscarinic antagonists, they work quite well in the acute setting, but for cough relief, cough suppression, which is not something that really we give routinely for that, but it does work.
Yeah.
And then actually things like Lyrica can also help just to kind of, it removes the stimulus for cough, not suppressing the cough. So that hypersensitivity, it removes. So that you can also give, obviously takes a bit longer to be effective. But in terms of acute suppression,
No.
You want them actually to cough because you want them to get all that stuff out,
Yeah.
unless it's excessive.
Yeah.
Guys online, Arti, any questions?
I've got two questions. Hi,
everyone. Hello.
Como, yes,
Can you hear me?
Kelly. We're listening to you.
Hi, Darren. Thanks so much for a great talk. Thanks, Darren, for a great talk. You might have gone through this. I just know in the event where the patient is actively hematizing, and you have to protect the human tissue and so forth and so on, and you actually try and intubate the lung that is bleeding. Now, do you know which lung is bleeding at that point when you are going to intubate the patient, or is it the X-ray that helps you to see which lung could be bleeding?
Yeah, so there's two ways. So either the X-ray can lateralize, which it can often do. So if you've got X-ray, you can presume based on the pathology which side is actively bleeding. Otherwise, when you intubate, you do a bronchoscopy at the same time, and you can see from bronchoscopy which side is bleeding, and then you can even use that to guide the tube down the right bronchus. So either you do it under vision or based on X-ray imaging.
But sometimes it's also difficult, really. The problem that sometimes, if they have life-threatening bleeding, sometimes you find both lung actually, when you do your bronchoscopy, you see that's having all blood. So what you need to do, you obviously need to clear the airway first when you do your bronchoscopy, have your cold saline, and try to guide until you localize the bleeding. Because, I mean, it's very important when you do bronchoscopy to actually localize the bleeding, because that will guide you about what position you want to put your patient on and where your tube should go. So it's very important that you don't panic when you actually do the bronchoscopy. You have to be, but you also have to be very efficient as fast as possible to kind of localize the bleeding. I think it's very important. But sometimes radiologically or actually bronchoscopically it can become difficult to see, because sometimes, again, patient can have medical bleed that they bleed from everywhere in the lungs also, so you might not even localize it. So I think the most important, just make sure that when you do bronchoscopy, make sure you go to your cold saline. You must have your tranexamic acid, and so that you can be able to kind of reduce so adrenaline and all those, to make sure that you're more in control. Otherwise, you just do bronchoscopy, then you really get yourself into disaster also with quite a lot of problems.
The clinical exam not helpful.
Perfect. Yeah.
You can't localize on the stethoscope side.
It's difficult. Okay, chat questions.
Thank you very much.
Thanks, Kelly. Thanks for joining in.
Okay, so there's a chat question, and it's asking where pulmonary TB is prevalent, how low will your threshold be for bronchoscopy? So again, we bronch patients with TB all the time, intentionally or unintentionally. So as long we always bronch with an N95. So we try and be as safe as possible. It's from South Sudan.
Interesting.
So really, the question with bronchoscopy is, what are you aiming to do by doing the bronchoscopy? So if you still don't know where the bleeding is coming from, then bronchoscopy is useful in that sense to try and locate the bleeding. If you know that the patient has got pulmonary TB, or you see cavitatory change on your imaging, you don't really need a bronch, because you can send sputum to prove the TB or disprove TB, and you can see the lesion, and you rather plan for a procedure when the patients are stabilized, because you won't bronch then in terms of bleeding control. It's unlikely to be that helpful. So really you need to do a bronch when the indication is there for it, and usually that means localizing a bleed. And whether the patient has got TB or not, we will usually go and do it because we don't know at that time.
But also, I think one of the things that if you're suspecting TB, remember, you don't need to have a culture positive to treat TB. You can also use empirical and using epidemiological data on your area or in your country or within your city, how prevalent the TB is. Because some of the previous TB already with underlying damaged lungs, most of those patients, the chance of recurrent reactivation TBs are very high. And normally when they're having heamoptysis, we normally suspect TB. So sometimes you're safer to start on TB treatment than actually doing any procedure on them, and then consider that while you're waiting for your sputum. But again, you put in that most of these patients, the culture takes about 6 weeks, so you can't wait. So remember that one of the important things that anybody who having bleed in the lung means there's underlying problems, and you have to address it. You can't just stay out from it, you have to address it. And that one of the TB, unless you can culture like streptococcus pneumonia or viral, whatever is there, then you treat those first and then see whether the bleeding can stop. If it doesn't, then you need intervention as urgent as possible. But again, bronchoscopy is not going to help you in the post-TB bronchiectasis or mastectomy, because you really know where the source of the bleeding, where it's originate. So those patients, ideally, they need to go direct for embolization, if I'm not mistaken, Darren. Yeah, so you need to do that directly. But thanks for joining us from Juba, South Sudan. We appreciate it. And the podcast will be available, I think, next week on the website. And please share with some of the students that are studying in Ethiopia, doing internal medicine, or around Kenya, so that they can access the up-to-date information. And yeah, in case they didn't come, they can join us. Question?
Down to one now.
Uh,
Down to one question now.
well, we'll make it.
1.5.
No, so the one is, I had a patient with heamoptysis, turned out to be a Klebsiella pneumonia. In cases like that, so if you've got an organism, the heamoptysis setting, the scan is okay, nothing that worries you, you would then just continue treating the patient, and you wouldn't really go and over-investigate the patient.
No.
So, and just follow up with a routine X-ray afterwards to make sure it's
so obviously Klebsiella can give you a necrotizing pneumonia.
Yeah.
So it's good to follow them up, because you want to see how is the lung actually resolved after that infection.
Yes.
But generally, no, once you have the cause and the patients are settling, continue your treatment, and that's it.
My second question is also for EC, I think. So we're very fortunate that patients come with scans, so they will get X-ray. So what is the options of CT scan, CTPA versus high resolution? Is there any one that you particularly want? For a patient that comes in with heamoptysis. So is there one that you would prefer?
Yeah, you would want contrast.
Yes, contrast.
Because
so CTPA,
the vascular problem.
Yeah.
So you want to see it. So things like AVMs you'll miss if you don't give contrast. It'll just look like consolidated lung.
Yeah.
I think that probably the important question here is, when do you do CT scan with contrast? And most of the time, heamoptysis, if you suspect vascular problem, and also when you suspect pleural disease, then contrast is really indicated in those aspects. High resolution CT scan really for where you're not concerned about vascular, and also you're not concerned about pleural disease. That's why we do CT scan, especially emergency center.
So yeah, it's a common, I don't know, when the patients, I admit, where the patient might have needed a contrast scan and got a high res, or might have only needed a high res or preferred a high res but got a contrast scan. And now do you give them a second scan for the cost and the radiation exposure, or do you rely on what you've got? It's tricky. So ideally, the person who requests that scan should have a little bit of insight into what they're looking for and request the appropriate study. So if it's a parenchymal thing, high res is better. If it's vascular in some form, or there's a worry about a mass, then contrast is better. So just you kind of need to.
And CTPA give you the same? It's because then you rule out PEs and all those.
Exactly.
Questions?
Hi, morning, guys. Thanks very much for the presentation. Just a quick one with regards to the cyclocapron. I see that they recommend that it's a 500 milligrams 3 times a day dose, but in the EC, is there any role for giving a repeated dose, or do you give both the nebulized cyclocapron and the IV cyclocapron? So just with regards to that.
So the IV is used, and you can use it together, but there's no evidence for it. So they will give a gram stat and then 500 TDS IVI. But again, there's no evidence that systemic therapy actually makes a difference. but it's relatively safe. The side effects are quite few, so it is used. You can give a stat dose and see whether it's effective. It's not a problem, but there's not good evidence for it.
Yeah, I think also emergency setting. Yeah, I think you don't forget your morphine and your codeine. I think they also do also assist to reduce the bleeding. But I think inhalation probably the right choice. Unless if you're really suspecting a systemic kind of or medical kind of bleed. I don't know whether there's role for that, like somebody with warfarin toxicity or low platelets or probably a bit of low fibrinogen that could have been the cause of it. Or, I don't know, then maybe there's a role of systemic, but I think probably we need to look at the data and evidence to see what it says actually.
Okay, thanks. And then with the inhaled cyclocapron, is there room to do a repeated dose if the first one is working, or is it strictly every 8 hours?
Well, there's no evidence to do it, more than that. That's
okay.
So I don't think there's a huge problem in terms of risk, but that's the recommended dose from the studies.
Okay, cool. Thanks.
Thank you.
Thank you, everybody. Hope you all have a good day. Thank you for joining online. Thank you so much again, Darren.
Thanks.
And next week, podcast will be available. You can log in case you missed the discussion today. They'll be available on podcast and it's read on the website. We'll send a link once it's been loaded. Yeah. Thank you, Diane.
Thank you.
And looking forward, I think our next week topic, we have quite two lovely topics coming up on the second. The most important topic is about the indication of blood transfusion in Jehovah's Witness. And it's really going to be a very good discussion because I think we struggle with that case. With those cases, we kind of admit Jehovah's Witness patients and they struggle. I think Joseph admitted one few weeks ago, last week or so. And it was really a big battle because the patient was dynamically unstable. So we're going to really have to discuss, have an expert to give us an insight into what to do actually, what are the other factors that we can use in Jehovah's Witness patients. And I think on Thursday, what are we presenting?
Not sure.
On Thursday, maybe we'll also have a presentable approach to chronic cough. Thank you, guys.
Thank you.
Thank you, everyone. Thank you, Dr. Taban. Much appreciated. Thank you, Darren, for the presentation.